Yes, sir.
Wait,
1 minute.
wait a minute. Wait a minute.
1 minute.
Yes, sir.
Yeah.
Once. I'll make this full screen. Yeah.
Yeah.
He's a 4.5-year-old male born out of a third-degree consanguineous marriage, hailing from
Wait a
Kallakuri.
minute. Wait a minute. Wait,
Yes, sir.
wait. Before
I'll
starting,
just start introduction.
yeah. You have to, we will have a small introduction, then we will start.
Yes,
So
sir.
that
Sure.
the people who are joining, they should know what is the case.
Yes,
And,
sir.
Okay.
Yes, sir. Yes, sir. Cool.
Good evening to one and all who have joined here with us today. Today we'll be having a pediatrics case presentation on hepatospleenomegaly. The case presenter is Prem Sai, third year from JIPMER. And to mentor the case, we have two of our most distinguished faculties, Dr. Prithviraj sir, junior resident, Department of Pediatrics, Badwan Medical College, West Bengal. Along with him, we have Dr. M. Karthikeyan sir, MBBS DNB Pediatrics and Fellowship in Neonatal in Indra Little Hearts Clinic, Tamil Nadu. I welcome both of you, sir, and the session is all yours. Prem sir, you can start.
Yes.
Yeah.
Yes. So thanks. Yeah.
So good evening to one and all present here. Today in our second session of case-based discussion, in our first session we discussed about nephrotic syndrome, and today we are going to see a case of hematological case, which is very most common case that has been kept in all university examination as a short as well as long case. So we will be seeing this case, and along with it, we will also see some approach of the hepatosplenomegaly with and without fever. So how to proceed with the cases, and then we will have a small discussion after the case discussion. So now I will give the mic to Prem Sai for case presentation.
Yes, sir. Thank you, sir. Yeah. Everyone, can you hear me?
Yes. Everyone is ready. You can start.
Yes, sir. Yes.
Start soon.
Today's case is about Mr. Sri, who is a 4-year-old male born out of a third-degree consanguineous marriage. He is hailing from Kallakuri, Tamil Nadu. The informant is his mother and is reliable, sir. And the chief complaints are he is having pallor since 4 years, and he's on regular blood transfusions since then. And he has distension of abdomen since 3 years, along with cough and coryza since 7 months. 7 days.
7 days. Okay. Okay.
History of presenting illness. Sri is a known case of blood disorder and is on regular blood transfusion. Initially presented at 7 months of age when mother noticed progressive pallor and decreased activity and fast breathing. So she came to the hospital and the child was given blood transfusion. Based on blood testing, he was diagnosed with some blood disorder. Since then, he was receiving blood transfusions every month, and now he requires blood transfusion every 2 to 3 weeks.
Okay.
Yeah, and the mother also noticed there is distension of abdomen, especially in the upper part of abdomen, by 2 years. First, it appeared on the left side, and then it progressed to the right side also, and then distension has been increasing since then. And the patient also has cough and coryza in 7 days, and the cough is non-productive, non-spasmodic, without diurnal and postural variations.
Okay.
Coming to the negative history, there was no history of painful limbs and swollen hands and convulsions. There was no history of yellowish discoloration of urine, but there was discoloration of eyes, yellowish discoloration of eyes. Okay. There is no history of pica, no history of worms in stools, no history of recurrence of loose stools, and no history of fever with chills. No history of bleeding and bone pain. No history of fever also. And there was no history of irritability, lethargy, breathlessness, fast breathing, edema of Frutter also. Those are also not this. There was no history of polyuria and polyphagia. The past history, there was no significant.
Can you elaborate why you asked for all negative histories?
Yes, sir. Painful. There was no history of painful episodes of limbs and swollen hands and abdominal pain. This usually occurs in sickle cell anemia. In sickle cell crisis, yes, sir. In hypoxia conditions and when there is respiratory acidosis, sickle cell crisis occurs, and then it leads to vaso-occlusion, which leads to pain in limbs and abdominal pain.
Instead of that episodes of painful limbs, you can directly say bony pain or any painful event in the chest like that. Okay. Most common
Yes, acute
presentation of
chest
sickle
syndrome.
cell anemia is crisis, pain. Okay. Next.
Yes, sir. And then there was no history of yellowish discoloration of urine, which shows that there is a high hemolysis. So we can
But in thalassemia, you may expect some amount of hemolysis.
yes, sir.
Okay. Okay.
History of pica reveals that there is no nutritional deficiency of iron.
Okay.
Yes, sir. And history of worms in stools also, it also refers to the iron deficiency.
Okay.
Recurrent loose stools also refers to the deficiency of folic acid and B12. And fever with chills refers to malaria, sir.
Okay.
Okay.
So, in history of recurrent loose stools, that also malabsorption kind of syndromes. So, like many malabsorption leads to iron deficiency and megaloblastic anemia. Okay.
Yes,
Then.
sir. And there was no history of bleeding from any sites, no history of fever, bone pains, and neck swelling. This all refers to lymphomas and leukemias.
Okay.
No history of lethargy, breathlessness, fast breathing, edema feet. This all refers to heart diseases, sir, like chronic heart failure and
Congestive cardiac failure, you can say.
yes, sir.
Okay.
No
So
history
that
of
irritability, all other things, it may because of iron deficiency anemia also.
Yes, sir.
Okay.
No history of polyuria and polyphagia refers to diabetes mellitus, sir.
Why
How diabetes
asking
mellitus here? Why diabetes mellitus in this scenario?
Because there is excess of iron, sir. Because of that, it induces insulin deficiency and
very good.
it leads to.
So you can divide your history like first, what is the presenting complaint? Then you came to know some kind of diagnosis. Then rule out similar differential diagnosis, etiological history. Then according to the treatment, you can ask what are the side effects. So you need to ask relevant history. That is the ideal way of asking presenting history, I think. Okay.
Yes, sir.
So anything else you want to ask? Like you asked history of convulsion, it's only because of sickle cell anemia or some other reason?
I don't know, sir.
Storage disorders also.
Glycogen storage disorders.
Okay.
Yes,
So you come to the first question, like in your initial pages. We start on history of presenting illness. What was the chief complaint for this patient?
The chief complaint was
Taylor since 4 years, and he was on a regular blood transfusion since then, and there was a distension of abdomen 3 years, and now the child presented with your cough and corona, right? So
yes, sir.
Now you tell me what does the word regular means? How would you define regular blood transfusion?
It means in like every.
Yeah, tell me.
Monthly, he used to have blood transfusions.
Okay, regularly monthly blood transfusion. So
yes,
as per the definition, it's regular blood transfusion said when the child is taking blood transfusion every 3 to 4 weeks for his proper growth and development. So then we can say it is a regular blood transfusion. If it is not, the child is not taking regularly, like more than 4 months, one time he takes after 3 weeks, after sometime he after taking after 5 weeks or after 2 months, then it becomes irregular. So that's the importance of adding this word regular. Okay, so that's the one thing you have to see. Well, by writing regular, you should know what is the definition, when to call that blood transfusion as regular, so that you will not get caught. And what was the next history of presenting illness?
Distension of abdomen since 3 years.
Okay, you come to the next slide.
Yes, sir.
So you know that it's a known case of blood disorder and he was on a regular blood transfusion. So for past from the age of 7 months, can you describe the hemolytic anemias according to the age of onset? Based on which age you will say this could be the possibility for the cause of the hemolysis in this baby?
At 6 months, thalassemia will start to present, sir.
Thalassemia?
Yes, thalassemia will start. Sickle cell anemia also, sir.
Okay.
And
Good.
when it comes, thalassemia intermedia will present at adolescence, sir.
Okay, it's not adolescence, it's more than 2 years. Okay.
Yes.
At birth, if anything that present hemolysis at birth, what would you suspect? What is the most common thing you have to suspect when there is an hemolysis soon after the child is born?
RH incompatibility.
Exactly. Good.
That is
Very good.
kind
Very
of
good. Yeah.
mediated. And anything
Anything else?
RH incompatibility and G6PD deficiency.
good.
Yeah,
Okay.
severe G6PD deficiency, severe pyruvate kinase deficiency will present, and any other thing? In what other thalassemia can present at birth?
Yes, sir.
Which thalassemia will present at birth? Which
Uh,
thalassemia?
alpha thalassemia.
Yes.
Good, very good. Why? Why alpha thalassemia presents at birth, not at why not at later? Right? We have learned that thalassemia always present at 6 months, but
Yes,
why this alpha thalassemia presents at birth? What is the reason?
because alpha protein is also present in HbF also. So
Very good.
it takes
Exactly.
6 months
Good.
to.
No, that's the answer. Because alpha globin is important for your fetal hemoglobin also. So
Yes,
when
sir.
that is not going to be formed, the child will present at birth itself. So you should know when at the age of onset. So that's the so based on the age of onset, you can know which kind of hemolytic anemia the child may be suffering from. And he has been a regular blood transfusion. And yeah,
Sometimes
now you say,
hereditary spherocytosis also can
Present.
possible.
yeah, yeah, this is also important. Yeah, as sir said, hereditary spherocytosis will be present with severe hemolytic anemia at birth, and sometimes the child may require blood transfusion, exchange transfusion because of severe unconjugated hyperbilirubinemia. These children may go for a chronic kind of stage, and may require EG. So they present initially at this past 6 months of life. Now you
So
say the
here,
since. Hmm.
yeah, just you asked, you said they are from Kallakurichi, is it?
Yes, sir.
That native place is very important for this kind of scenario, or it's not important? Like,
Uh, the place of origin might reveal data about their. Generally, some places have nutritional deficiencies, like
Good.
that's okay.
Apart from that,
Even
apart from that.
apart, um,
even thalassemia are also endemic in many states like Odisha, Punjab, even in Tamil Nadu, Salem and Dharmapuri areas also endemic for thalassemia. So
yes,
that's
sir.
why why those
Uh,
areas are endemic for only for thalassemia? Why not for others?
Because thalassemia is autosomal recessive, sir. So the marriages will happen within those local regions.
Yeah,
Okay, very
consanguineous
good.
marriage. One thing is that, and one thing is about that's the reason why asking about this area location reason is most important because to know you should have some idea about the thalassemic belt and sickle cell anemia belt. In Tamil Nadu, thalassemic belt, as I said, is about Salem and Dharmapuri, and you go to Zavadu Hill. Zavadu Hill at Tirunelveli district, it's more go in favor for sickle cell belt. So you will see more
Yes, sir.
sickle cell anemia cases in that Javadu Hills. So that's the reason. That's the reason why you should know some basic knowledge about the location, so that it helps you to. That will be giving a favorable supporting point for the diagnosis. Okay.
And one
Now you
more
are saying that.
interesting point,
Hmm.
wherever if you are having more thalassemia, more sickle cell anemia, those areas are endemic for malaria also. So whenever hill station, more rain, more malaria, more mosquitoes, then more malaria. Then for that purpose only hemoglobinopathies will be there from protection of malaria. Okay.
Okay. So now, when you go for history of presenting, third point, you are saying that since the child is receiving blood transfusion almost every month. But
Yes, sir.
suddenly the child is having a blood requirement of blood transfusion has become to every 3 weeks. So what could be the reason? What does this indicate? Initially, he was getting blood. Yeah, you tell.
Accelerated hemolysis, sir.
So accelerated
Like
hemolysis in what way?
in what way?
What was the causes?
As he's growing, no, sir. Like is
Mhm.
growing, so there is a excessive increased requirement of hemoglobin production. So
So when something is required more, so what the body will do? What the body needs?
uh, more nutrition.
Good. What nutrition that body needs for RBC production?
So, they folate and B12.
Very good. Exactly. If there's a
Yes, sir.
concomitant folate, whereas iron deficiency on the vitamin B12 deficiency, there will be an increased requirement of RBC transfusion. And second thing is increased destruction, as you say, accelerated hemolysis. So where does this accelerated hemolysis occur in thalassemia?
It occurs in spleen, sir, mostly.
Exactly. So there will be a splenomegaly. But that condition is known as accelerated destruction of RBC in spleen. What you say? What is the term used for?
Extravascular hemolysis.
Yeah, extravascular hemolysis. But this is accelerator. When it becomes accelerator, the child
Hyperspleen.
yeah, exactly, very good. Yeah, it is hypersplenism. So when there is a concomitant iron nutritional deficiency, and that is an any case of hypersplenism, then the requirement of blood transfusion increases. Initially, he was taking frequently 1 month. Now he is taking 2 to 3 weeks. So you have to correct that cause. So you should know why this is happening, why the requirement is increasing, and what could be the cause, and how I will correct with that mindset. You should tell that during your treatment also. So during treatment, what you would do for that same case. Okay, so go to the next
Yes.
slide. Okay, so distension of abdomen. So what does this mean?
Distension of abdomen.
Hmm. So what do you want to convey from this abdominal distension? What the mother is saying, and how do you correlate with the case?
Mother said that she showed the baby, and she was telling that like, the stomach was distending, and correlation like towards the left side. It started towards the left side. It means there is
Mm-hmm.
first the enlargement of spleen, and then
Mm-hmm.
there is
Good.
enlargement of liver. So
Very good.
splenohepatomegaly.
Cool. So this is the history of presenting illness. Okay, good. So, and now at present, the child came for LRT, like cough and coryza. He's having
Cough and
some kind of
coryza.
viral infection for which the mother has admitted the child. Okay,
Mm.
go to the next slide. So you have already explained all the negative histories. So as Sir said, when you are taking a negative history, you should the reason for taking a negative history is to rule out some few important things. One is the patient has came with some pale abdominal distension and increased requirement of blood transfusion. So you should know what could be the etiology. To ruling of etiology, you should have some kind of history to, like, it could be a sickle cell anemia, or because of iron deficiency or nutritional anemia. So etiological history. Second is treatment history. So if the child is a known case of something, so you can ask some kind of treatment history that could be asked in the history of presenting illness itself. And third thing is complication. Complication because of the disease. What are the complications you're expecting for that particular disease? That could be asked in the negative history, and complication due to the drugs we are using for the drug. So this could be the way you have to ask. So etiological history, second, the history of the disease by per se. What could be the disease can cause in the baby? That should be the second line. And third thing is the history of complication. That complication may be because of the disease itself, or it because of your drug itself. In that way, you should ask your negative history. So as sir discussed everything, so that way it's more or like okay. Okay. So go to the next slide. Continue with the case.
Yes, sir. There was no significant past history. Uh,
Okay. So
treatment history.
yeah, you can, yeah.
The treatment history, he was on regular oral medication, which was taken on
Hmm.
empty stomach in the morning along with milk. And he started it at the age of 2 years. And there were other medications also, but the mother was unable to tell. Sir.
Go to
Okay,
past
good.
history once again. Past history.
Passes.
Right.
Hmm.
Okay, so in this past history, this child almost used it regular transfusion almost last 4
Yes,
years.
yes, sir.
what surgery you want to ask him first? Said it's surgery.
Surgery.
Now, what surgery you will do in this case? Surgery is nothing.
Splenectomy, sir.
Yeah.
Okay, fine. So in past history, do you want any other history? Like this child had any jaundice, anything,
Yes, sir. We would like to
and
ask
any
if
medication?
there was any icterus, and if there were any symptoms of liver disease or something like that.
Okay, so causes of jaundice in this kind of scenario in past history. Why these children are prone for jaundice?
Because there is a hemolysis, sir. There might be formation of pigmented
Very
gallstones.
good. That is the one reason. Undergoing hemolysis.
Hemolysis, biliary obstruction due to pigmented gallstones.
Okay.
Good. Any other thing? Most common thing. The history itself, with the first history itself, it's a known case of no blood disorder and it's on a regular transfusion. So, what would be the other cause? If it's on a regular transfusion, what you will suspect? If the child is suddenly developing jaundice.
Yes, sir. Because of immune reactions.
Immune reaction is an acute process. Apart from that,
Very good. Minor blood group incompatibility we can accept. Okay.
incompatibility. Okay. Any other thing? Recurrent blood transfusion and the child is developing jaundice.
Blood transfusion related infections, hepatitis B and hepatitis
B and hepatitis
of
B and C.
good vaccination coverage. Nowadays, hepatitis B incidence is less, but still hepatitis C incidence is higher. Okay. So, and one more reason is drug induced.
Yeah.
Okay. So that 4 reasons are there. Kind of scenario where the babies are prone for recurrent transfusions, and they may have jaundice because of these reasons.
And one thing you should know, by the way, like thalassemia, normally in thalassemia, jaundice is not a complaint. Okay, the patient never complained with the jaundice. You will be coming paler, fatigue, abdominal distension. As your history also says, suggesting same only. The child had a mild icterus, but that was not the complaint of the parent. The complaint of the parent was the child is paler, fatigue, and the abdominal distension and requirement of blood transfusion has increased. So this is not a complaint. They told that the child is having a yellowish discoloration of skin, because thalassemia rarely causes jaundice. So you should know that when a thalassemic child is becoming jaundice and icteric, and the mother is saying that particular complaint, then you have to always suspect it is not because of thalassemia. There is other cause. One thing is drug induced. Second is your infection related like hepatitis B and C, and third is iron overload. These are the 3 major causes that will leads to jaundice in thalassemia. Okay.
Yes,
go.
Antenatal history, it was a booked case, and the TT was taken. Vaccine was taken. Iron folate was taken accordingly. There was no fever, rash, or rash, and there was no exposure to radiation or drugs. Anomaly scan revealed no problematic findings. It was normal. The natal history, it was full-term baby. Birth weight was 3.2 kgs, but the patient was admitted.
Wait a minute. We will make it full screen. You make it full screen. Yeah. Now you see.
So the baby was admitted into NICU, sir, and blood transfusion was initiated soon after birth.
Now wait a minute. Why the blood transfusion was initiated soon after birth? What was the cause? I guess you wrote it wrong. If it was a blood transfusion initiated soon after birth, the child was having a severe hemolytic anemia at birth itself. It either could be RH incompatibility or ABO incompatibility or severe hereditary spherocytosis or any enzyme deficiency. Did you ask what was the reason for giving a blood transfusion during birth? Or it could be because of severe hemolysis and the child was having. Did you ask this history properly with the parent? What they were telling?
They told that. They told that NICU admission was there, sir.
Okay, good. NICU admission for how long? For how long?
Yeah. For what reason? So this blood transfusion may not be because of linked to this
Yeah,
hemoglobinopathy.
yeah.
There be another reason. But I want to ask one more question. Like
yes,
you are kind of medical officer sitting in one PHC.
yes, sir.
One mother is coming for antenatal visit. What investigation you want to do on that mother to rule out hemoglobinopathies? You have only limited sources there. Okay,
Family history first, we'll ask.
very good.
We'll,
Family history.
Very good.
family history.
What
Other than
families? What families you will be asking?
if there is any history of disorder,
Recurrent blood transfusion, any splenomegaly.
if there are any affected children because of that.
Yeah, that's true. By history, if you want to do one investigation from that, you can rule out. So it's very simple investigation.
US.
No.
No. You are
So
sitting in
complete blood
UPSC.
picture. Complete blood picture is enough to
Hemoglobin.
see
Very
the
good.
RBC incidence like
Yes, sir.
MCV, MCHC, red cell distribution with Mainster index. These are all is very basic investigations. You can rule out easily even thalassemia intermediate and like thalassemia minor as well as thalassemia major. Okay, to differentiate from iron deficiency anemia. No need to do HPLC.
Yes, sir.
Okay.
So that we will discuss in investigation part once again. But you should remember, because
Yes.
like Amitabh Bachchan, Roger Federer, they are carriers. They don't have any symptoms. Even those mothers, they don't have symptoms, but they may be a carriers. We can easily pick up by CBC only.
Yes, sir.
So for how long the child was admitted in NICU? Have you
For
asked
4
that?
days. For 4
For
days.
4 days. And so the child was for what reason the child was admitted? Have you asked? Blood transfusion is there, but
Blood-
what was the reason for admission? The child is a full-term baby and he has a good weight also, 3.2 kg. So not for any prematurity and low birth weight, the child was not admitted. So for what was the reason for admission? Did you ask that?
that I didn't. That I didn't ask.
But you should ask because a term baby with a good weight of 3.2 kg. So unless there is some complication, they will not admit in a NICU. So you should also ask, and what was the reason for blood transfusion? If this history is significant, then the diagnosis will completely change. If you are getting it
Yes.
right, the diagnosis will completely change. Okay.
Hmm.
Okay. Then next.
Postnatal history, there was no neonatal jaundice, and the baby was breastfed for 6 months. And
Okay.
developmental history, the baby was normal, and he was able to climb downstairs, and he was able to put dress on his own without any assistance.
Good.
And nutritional history, he's a non-vegetarian, and he takes three main diets along with biscuits also, and he consumes 1,300 calories per day, along with which contains 12 to 15 grams of protein daily. And he
Okay.
eats green and leafy vegetables in less amounts and occasionally.
Okay. So what you want to tell with this history? So what any protein deficit? Any protein deficit is there or any calorie deficit is there?
Calorie deficit is not there, sir, but protein deficiency is there.
Okay, calorie. How much required a child as per the RDA requirement for the child? This is 4.5-year-old baby boy. So what is the requirement, actual requirement of calorie for the child?
That I
What
don't
is the
know.
weight of the child? What is the weight of the child?
For weight of the child currently, okay.
Yeah, at current. At
Current
present.
weight I didn't. I didn't.
Now, while examination, what was the weight?
I should check. Sir. I don't remember exactly.
Okay, so most likely if you take per kg, we say, it's a holiday Segar formula. So based on that, we do that. So if the child weight is around 4.5 kg, 4.5 years mark, more or less the child weight will be 14 kg to 10 to 15 kg. If you take 15 kg, then it's around 1,300 kilocalorie. If he is around that, if this 1,300 calorie okay, then okay. And if 15 kg, 15 gram protein is the one thing. Yeah. So I guess both are equal only. At present, there is no deficient. if if we take the weight of the child around 13 to 15 kg. But we should
And
know the
one more
actual
thing,
weight.
you aware about this child is having hemoglobinopathy, no? So
Yes,
here
sir.
weight is mandatory. That is the first thing you need to check also, whether the child is failure to thrive or the child is having adequate nutrition. Depends on the child weight only we came to know. Okay. So weight you should know.
Yeah, that's one thing. Okay.
Immunization history is immunized up to date.
So, okay. Immunization history. What is the important immunization history you have to ask for in any hemolytic anemia case? Chronic hemolytic anemia case?
Hepatitis B. Hepatitis B.
Very good. Exactly. Good. Hepatitis B vaccination is very much important. Okay.
Apart from that,
Family.
they should, you can ask hepatitis A also. Okay. So, and any booster dose of hepatitis B the child may receive or not. Okay. That also we need to ask. Because the recurrent transfusions, nowadays we are recommending boosters once in 5 years also. So vaccination schedule, whether they are following national immunization schedule or IAP, which one, okay. Those are all very important.
Okay. Next, family history. Okay.
Yes, sir.
So,
Family history was born out of third degree consanguineous
mm,
born out of third degree consanguineous marriage, frequent blood transfusions, sir. There were no surgeries and prolonged jaundice in any cases of families.
okay. Here, what do you mean by consanguineous marriage?
Marriages within the family, like
So, what? How do you classify the consanguineous marriage? You are saying third degree. So, what is first
yes,
degree?
sir.
What is second degree? And what is third degree? What
First
is first
degree
degree?
is having the same grandparent.
Mm, no, yeah. Same grandparent means
In the sense like mother's brother or sister, like, and that. Sir.
no. It's not like that. First degree is always like brother, sister, brother, mother, son, and first relative, a first degree
Yes.
relative. So it's like incest.
Yes, sir.
Incest. That is kind of incest, then it goes in favor of first degree. And in first degree consanguineous marriage, you have 50% chance of your genetic diseases. 50%. 50% chance of getting a genetic disorder. In second degree consanguineous marriage is the mother's brother or father's sister if getting married to the son or daughter.
Son
That
or
is the
daughter.
second degree. Yeah, son is getting married to the father's sister,
Sister.
or daughter is getting married to the mother's brother.
Okay.
This is second degree. If in that case, it is 25% of inheritance of your genetic disorder. And in your third degree, it is your nephew or niece if they are getting married.
Yes.
That is third degree consanguineous marriage. And in this, the the percentage of genetic disorder that is inherited is 12.5%. So that is the reason why we are focused about why we are asking this consanguineous marriage, because how much hereditability of the genetic disorder is present. First degree 50%, second degree 25%, third degree 12.5%. So it's a third degree, so that's more chance of the child may get some genetic disorder. So 12.5% chance is there.
Yes, sir.
Right? Okay. Next.
Socioeconomic history. The family lives in a rental house. 3 members are living in a single room with a separate kitchen. And the father is a graduate and mother has studied till 10th standard. So family earns 15,000 a month.
Okay.
General physical examination. The patient was conscious.
For that,
Before going
summarize.
to that, summarize the history. Yeah, you have to summarize the history and you should know what system you want to examine and then go for a general physical. This should be your format. Okay.
Yes, sir.
You just summarize. So what you have told with a positive finding, and then you tell why you want to examine the system. So you should give your logical explanation before going to the examination. Yeah. You summarize the case.
Yes, sir. The patient the patient is a 4.5-year-old male presented with since 4 years and the abdominal distension since 3 years and he was having cough and courageous since last 7 days, and
Okay.
on eliciting history, there was a history of frequent blood transfusions, which were 1 month in frequency before, and now it reduced to 2 to 3 weeks, and there is no the baby was born out of a third degree consanguineous marriage, and there was no history of no family history of any blood disorders.
Okay, so you have told all the thing, but in order to concise and how to tell, you say it is a 4.5-year-old male child, first order or second order, born out of third degree consanguineous marriage, belonging to uh, lower upper or
Lower
whatever
session.
to some scale, now developmentally normal, humanized or vaccinated up to age, presented as it was a known case of hematological disorder, having parallel for 4 years, abdominal for distension for 3 years. At present, the child is coming with a complaint of cough of coryza, as most likely a viral etiology, and with no significant family history, except for the third degree you told, and with any nutritional deficit is there, any calorie deficit or protein deficit is there. And so, most likely, since the child is a known case of hematological disorder on a regular blood transfusion, I would like to examine the reticulo uh, endothelial system, which comprises of a liver, spleen, and this. Okay, so I would like to examine reticuloendothelial system for uh, kind of for further evaluation, like that you can say, and you should say some possible diagnosis. So, what is the possible diagnosis you are having right now? Possible differentiates. At this
Possible
time,
diagnosis is hemolytic anemia, sir. And I would like
it
to
is a
perform
chronic hemolytic anemia. You say it's a
chronic.
chronic hemolytic anemia.
Yes, sir.
Yeah, chronic hemolytic
Chronic.
anemia, like
Chronic hemolytic anemia, and it might be, and I want to do abdominal examination so I can confirm the diagnosis.
okay. So
Abdominal
most
general
likely,
examination.
yeah, okay. You go for general examination.
General physical examination, the patient was conscious, oriented, and cooperative. Weight was 17
Okay.
kgs, 50th centile for weight per age. Height was 106
Now,
centimeters.
now one thing, when you are saying orientation, so what is the age you can examine the orientation of the child?
Uh, like from 3.3.5 years, we can start to ask for the orientation. Where is he?
No. Normally, to be on safer side, you tell it's always about more or less 7 years. Okay.
7 years.
Before 7 years, yeah. Before 7 years, no need to say orientation because the child doesn't know. He has not started to school or he doesn't know how to tell. He just know that he says somewhere, but he cannot tell the oriented to time, place, person. Okay. So at this age, 4.5 years, don't use this word orientation. You can say conscious, cooperative, obeying command of mother, listening to mother. So this is the way you can say how he's interested in surrounding or not. You can say whether he's interested in surrounding or not, whether he's obeying the command of his mother, whether he's comfortable. This is the words you can use at this age. Orientation should be used better to use above age of 7 years. Okay.
Yes. Height was 106 centimeters. Head circumference was normal, sir.
Okay. So, what
Instead
do
of
you?
normal, always mention the exact numbers. Okay.
Yes, sir.
Okay.
Vitals.
So, according to your anthropometry, what do you infer? So, you're with the help of with the anthropometry, what do you infer?
The baby is of normal growth only for now.
Good. So, that means the child is having a regular good blood transfusion.
Regular
That supports that the child is having. When you say a regular word, regular blood transfusion in your history, and as per the definition, I say every 3 weeks the child has to take the transfusion. for having a normal growth and development. The word normal growth and development should be supported with your physical examination, and it has been supported because the weight and height are within the normal range. So that means he's on regular transfusion. So this is one point that's favoring your history. Okay, good.
Yes.
Then
Coming to the vitals, the pulse was 110 per minute, and the pulse was regular. Volume is normal, and there was no radial delay and no radiofemoral delays. Respiratory rate was 32 breaths per minute, regular and no respiratory distress. Temperature was 36.5 degrees Celsius. BP was 100 millimeters by 60 millimeters in of mercury in height upper limb. In sitting position, SpO2 in room air is 98%.
Okay, you make it full screen. Okay, it's yeah, make it. One thing is that while writing BP for children, okay, in BP less than 12 years, we always plot a growth and height chart with based on the height preference with bit of height range. We plot it into 50, 25, 50, 75, 95 center. In that way, you should tell that the BP because for a child 100 by 60 for adult it is a normal, but for 4.5 years the baby it could be high also. It could be a pre-hypertension. It could be hypertension stage 1. For in order to avoid that confusion only, we follow a chart like you follow an anthropometric growth chart. For blood pressure also, we have a BP chart. So you have to plot it there, and you should say which centile. Systolic blood pressure falls in which centile, and diastolic blood pressure falls in which centile. So based on that, you can say whether the child's BP is normal for his age, gender, right? Okay.
And coming to the head-to-toe examination, there was frontal bossing, malar prominence, dental mallocution.
Okay, yes.
The child is alert, playful, and interactive. Severe pallor is present and mild icterus. There was no clumping, cyanosis, pedal edema, and lymph node enlargement. The JVP was not elevated, and there was no petechia or purpura, and ulcers in any part of body is also not visible. Upper limbs and spinal normal.
So now one thing, JVP not elevated. So better avoid it to tell before 6 years. Okay, JVP you cannot see a small child. Okay, after 6 years you say. Because or else the examiner will ask you to perform that. And if you fail to perform, then it will be becoming problem. Okay, don't say JVP less than 6 years.
True. So you said frontal bossing, molar prominence, and dental mold occlusion.
Yes,
why these things are happening in this side?
Because of extramedullary hematopoiesis, the like bones they'll have a hyperproliferation of bone marrow, and it leads to
Because of extramedullary hematopoiesis, flat bones they are producing more erythropoiesis. Especially your skull and facial bones. Okay, so that cortex usually will be thinning and medulla is widening. Especially in that skull, diploid cells are more prominent. That's the reason you can see these features. Usually that bony appearance will happen after 1 year. Okay, rarely we can see it metacarpal bones also. But in facial bones and other bones, it may take at least minimum 1 year.
Yes, sir.
Okay. So now, as you say, the child is having what these features suggest. What is we told these features like frontal bossing, molar prominence, dental malocclusion. So what do you say it as? What is the name of that particular? Yeah. Cool.
That is hemolytic cases, sir.
Yeah, hemolytic cases.
Usually occurs due to beta thalassemia.
Good. So now this hemolytic phases, so it is going against your regular transfusion. If the child is on regular transfusion, there must be not this kind of frontal bossing, malar prominence, and dental malformation. So this means the child is not getting his proper blood transfusion. So this point is going against the regular transfusion. One thing is height and weight is favoring your blood regular transfusion, but at the same time, when you go for head-to-toe examination, the child is having hemolytic cases. If the child is having a regular blood transfusion as per the prescribed rate, then the extramedullary hematopoiesis should not occur. This means the child is not getting an adequate amount of blood, or he is not in a proper run. And weight and that's the thing. Height and weight is normal for his age, but at the meantime, is also having hemolytic phases along with hepatosplenomegaly, severe failure that goes in against the favor of regular transfusion.
Yes.
Okay. Mm.
Coming to the abdominal examination.
Mm.
On inspection, abdomen is distended, umbilicus was in line, but it was slightly pushed downwards. There were no prominent veins, scars, and sinuses, or visible peristalsis. The quadrants move with respiration. Hernial orifices are normal, and genitalia are normal.
Okay, good. Then?
On palpation, it was warm to touch. No tenderness is present. Liver is palpable below 3 centimeters from postal margin. Firm in consistency. Margin is defined, non-tender, and surface was smooth. And the liver span was 8 centimeters, and left lobe was not palpable. There was a mass in left hypochondrium which moves with respiration. It is tender, firm in consistency, not bilaterally palpable, and 6 centimeters below the coastal margin it is suggestive of spleen at organ.
Okay.
Coming to percussion, on percussion, it revealed that there was no free fluid, and the liver scan was confirmed. On auscultation, there was no bruit. Bowel sounds are present and are normal, and the other systems examinations were also normal. CVS S1, S2 are heard, and normal bronchial respiration sounds.
Okay. In case of this, when you saw the abdomen examination, you see about liver and spleen, right? So, whether this liver span is normal for his age or it's more than the age? What is the normal cutoff for this age? What is the normal value for the liver span for the child? What is it for this particular age? What is the normal value?
Below 7.5.
Okay, so it is about 8. So most likely,
Yes,
yes, I must having hepatomegaly.
Yes,
So
sir.
spleen, so splenomegaly. So he is also having spleen. And tell me, what are the condition where you will see? What are the condition is associated with splenomegaly? Name few condition.
Chronic lymphoid leukemia. Chronic lymphoblastic leukemia.
CLL. Okay. For this age, CLL, see, CLL is not seen in children.
Okay.
CLL is not non-Hodgkin lymphoma. Okay. Spleen. So always go with infection. Never go with malignancy. Okay. You should have a systematic way. You should say first, most common is infection. Second, go for any infection, inflammation. Then you have a genetic or storage disorder, malignancy. So like that you go. If you go in that way, it will be very easy to remember. So what the infection you will suspect when there's a splenomegaly?
Malaria and infectious pneumonia.
Good, very good. Okay, malaria, infectious pneumonia, scrub typhus.
Yes, sir.
Okay, then
Kala Azhar also we can suspect from this.
Kala Azhar, very good. Kala Azhar. Kala Azhar, where do you think it is more common? In which region of our country Kala Azhar is common?
That I don't know.
It's around BR and Jharkhand. It's near your BR and Jharkhand. You will see Kala Azhar patient. So here this is I have seen one case of Kala Azhar. Okay, the child present with a chronic fever, hepatosplenomegaly, persistent fever. So when we did a bone marrow, we got that Kala Azhar. So it was a visceral leishmaniasis, which is more common in BR and Jharkhand. Okay.
Yes.
So what are the causes of splenomegaly?
Sickle cell anemia.
Sickle cell anemia will cause splenomegaly. Initially,
it will cause, and then autosplenectomy will.
Yeah, exactly. But as a dictum, what are the causes of splenomegaly in sickle cell anemia?
Because of occlusive crisis, then it happens.
Good, very good. Occlusive crisis, huh?
Occlusive crisis only. I know that
And
one.
splenic sequestration. Occlusive splenic sequestration. That is the
Yes, sir.
one thing. That is the most common thing where the splenomegaly occurs. Okay, good. Then what other causes of one thing is the sickle cell anemia, infection is called out, hemoglobinopathy is told. Any extravascular hemolysis happen, then you can say this is PD deficiency or like that you have a splenomegaly. And what about the storage disorder? Which storage disorder you will be very fond of? A patient coming with fever and splenomegaly. Okay, and that is some kind of you have some features of some metabolic disorder. Small faces is that, and the child is having fever, and only spleen is present. So which is the one? Yeah, tell them.
Gaucher's disease,
Exactly,
lysosomal
very good.
disorder.
Got exactly. Gaucher disease. There are a few cases that the where only with the help of splenomegaly they did the genetic study and they found it could be a Gaucher disease. Even isolated splenomegaly in any child, when you have ruled out all other causes, but the child still is having splenomegaly. Then go to do not Gaucher disease, type 3 Gaucher disease. Okay,
Yes, sir.
okay,
And
okay.
then
This,
how you can differentiate spleen and kidney and pal examination?
Sir?
Spleen and kidney, you are palpating on organ, left
Yes,
side.
sir.
You know it's spleen or kidney. What are the differentiating features on examination?
you already told, man. You already explained in the examination of left hypochondral mass. Same thing you have to repeat. Go to the
Movement,
other slide. Previous slide.
movement
Yeah,
along with
you,
respiration, sir.
you go.
Yeah.
Good, very
First you
good.
have
Which
to
will
know
move?
spleen is
Spleen moves along with
intra-abdominal organ.
intra-abdominal organ.
Kidney is
It's
retroperitoneal organ.
very,
Okay.
very good.
So
Good.
spleen moves with respiration. Kidney does not move
Kidney
with
does not move with
respiration. You are not able to tipping your fingers between costal margin and organ spleen, but you can tip your finger in between spleen and renal. I mean, like you can easily. And
Yes, sir.
kidney is bilaterally palatable. Okay.
Yes, sir. And,
Certain.
case summary.
Okay, you tell right now.
Yes, sir. A 4.5-year-old male born to third-degree consanguineous marriage presents with hematological disorder requiring regular transfusion since the age of 6 months. Recently requiring more frequent transfusions and child often being asymptomatic due to pallor. Along with pallor, asymptomatic, not due to that. The child is also on oral medications. Family belongs to upper middle class and the child was born out of third-degree consanguinity with adequate calorie intake and attained normal milestones and immunized as per immunization programs. And
So
on
here some
Okay,
examination,
now
controversy is there. So according to that income, they may be lower class or lower middle class, na? So you said you are
yes,
mentioned here is upper middle class. Okay.
okay. Yeah, you should see which class. What is the modified Kupasamy scale or not? What basis the modified Kupasamy scale is classifying the family? On what basis? What are the three parameters they look for?
number of people in the house, like income and the area.
No, they
No.
see three things. Education of the family. They see the education, per capita income, and
Occupation.
occupation. Yeah, these are the three things they have to look, and according to they classify the family into five classes. And always per year, every year, the income classification has been changing. The latest is 2023. So Kupasamy scale now uses 2023 income classification. So you should also know about which recent changes in the income classification, so that you can change that. The every time when the income classification changes, then it all the classes, the grade will also change. So you should also know about it. So what type of income classification right now they're using. Now you say
Yes.
severe failure. So okay, what are the causes of failure?
Iron deficiency anemia.
Okay.
Here is INC.
Then
Sir, severe.
yeah, tell it. Severe?
Iron deficiency anemia, megaloblastic, severe, usually due to severe blood loss first. Severe blood loss.
Okay. But either one thing, whether pallor is equivalent to anemia or pallor is something apart from anemia.
Apart from anemia.
What are the things
Not it.
pallor apart from anemia where you see pallor? Any one condition?
I'm not really clear about that.
Okay. Pallor is also seen in hypothyroidism. Okay. So anything when your metabolism is impaired, like in pallor is not only anemia, it's apart from anemia, we see say pallor as a common term. We interchangeably use the anemia is equal to pallor. But when you
Yes.
study your physiology, physiology chapters, they will say typically that pallor is not equal to anemia. One of the differential diagnosis will be anemia and all other causes of anemia, apart from hypothyroidism, any storage disorder where any genetic disorder, metabolic disorders also you can see this pallor in the absence of anemia also. So you should know the definition of pallor, what are the causes of pallor, because these are the things which the examiner will ask you. This is a common question every examiner will ask every student when you appear for your university exam, because pallor, icterus, cyanosis, clumping, lymphadenopathy, edema. These are the 6 cardinal features of general examination. All the examiner will ask this, and you should be thorough with all the 6 features. What are the cause? How this happen? So you should know in and out of this 6 topic, right? Okay. So hemolytic phases, mild icterus, splenohepatomegaly. What does this splenohepatomegaly means?
Like depending on the order of distance, order of enlargement, we'll tell whether it's hepatosplenomegaly or splenohepatomegaly.
So splenohepatomegaly causes, what are the causes of splenohepatomegaly? Where spleen involved more than liver?
In cases of hemolytic disorders, so G6PD and this hereditary spherocytosis, beta thalassemia.
And any infection? Which infection where you have spleen more than?
We already discussed.
Yeah, we discussed it.
Malaria.
Very good.
Yeah,
And one more.
malaria.
Kalasar also.
Kalasar. Kalasar also spleen. So these are the things you should know. When you write splenohepatomegaly, you should know the causes. Okay.
People also, spleen is more prominent than liver.
Then.
So can you say some differential diagnosis for hepatosplenomegaly with anemia apart from hemolytic anemias?
Hepatosplenomegaly with anemia. Liver diseases, cirrhosis, and
Okay, some kind of storage disorders. Yeah, good.
Cirrhosis.
So if I'm more specific, around 6 months of age, one child is presenting, one baby is presenting with hepatosplenomegaly and anemia means what you will think about it? Only hemolytic anemia or something else also? Some syndromic like Fanconi's anemia, congenital dyserythropoietic anemia, Schwarzman diamond syndrome. So you should look for syndromic features. If only anemia means you need to think about some syndromes. These are all inherited bone marrow failure syndromes. Okay. But you should not forget aplastic anemia never associated with organomegaly. So don't commit aplastic anemia.
Yes. The diagnosis.
So, if same kind of like I asked hepatosplenomegaly and anemia, one more question. Hepatosplenomegaly with anemia and bone involvement. What are the DDs? First one is hemolytic anemia.
Hemolytic anemia. Lymphomas and leukemias.
Very good.
Okay, but
multiple myeloma.
That comes under malignancies. Osteopetrosis.
Osteoporosis.
Percentage like hemolytic anemia. How to differentiate by clinically these two?
CBC and
No, without investigation, visual disturbance, okay? Because of that thickening of bone, optic nerve atrophy will be there. That's why visual disturbance is expected in osteoporosis, but it won't be there in hemolytic anemia.
yes, sir.
Oh.
Next, coming to the investigation, the
No,
investigations which
you said a diagnosis. Say the diagnosis.
diagnosis is this is a case of hemolytic anemia, which is probably transfusion
This is a
dependent
case
thalassemia.
of
Hemolytic
okay.
anemia, probably
Hmm.
transfusion dependent thalassemia, which is not in heart failure, but there is a recent history of hypersplenism and is on chelation therapy with normal growth and development.
Okay. Now a case of chronic hemolytic anemia. So that is the first correction. You should write a chronic. Okay. Probably transfusion dependent thalassemia. Okay. And not in heart failure, but recent history suggestive of hypersplenism and on chelation therapy with normal growth and development. Oh, okay.
Investigations will do CBC and peripheral smear to
Okay.
check for blood count and to rule out hereditary spherocytosis also, sir.
So how do you rule out hereditary spherosis by CBC?
In normal, sir, in hereditary spherocytosis, the central pallor of RBC is not seen, sir.
Okay. Okay. Then
We can
what
see
that known as? What is the most commonest cause of spherocytosis in children? What is the most common cause of spherocytosis in children?
Genetic cause. Genetic or hereditary only.
No, it's not. That's the reason why I asked that question. It's not your HS or genetic cause. What is the most common cause of spherocytes in children? It is your autoimmune hemolytic anemia.
Yes,
any child, any smear where you're seeing some spherocytes, always do direct test. If direct test is positive, then it's always go in favor of autoimmune hemolytic anemia, and you have to treat that condition accordingly. If only when the direct test is negative, then you have to evaluate for hereditary spherocytosis. So in any chapter, if you read any chapter, first differential, always they say to rule out autoimmune hemolytic anemia in a smear containing spherocytes. If that is negative, then only you have to go for the evaluation of hereditary spherocytosis. What is the second point you will see? In hereditary spherocytosis, the spherocytes are microspherocytes, right? It's a microspherocyte. Whereas your autoimmune hemolytic anemia will have macrospherocytes. So these are the differential point between your hereditary spherocytosis and autoimmune hemolytic anemia. And what is the screening test for what is the screening test for your hereditary spherocytosis? Which parameter you will see in the peripheral in your CBC to say
MCHC.
Very good. What is the cutoff value?
Cutoff value greater than 16 grams per deciliter.
No, that is hemoglobin. It is 34.5, right? If any value that goes for beyond 34, it is 34 or 36, 36.5, I guess. No, it is 34.5. Okay, it's any value that's more than 34.5 with RDW, which is a red cell width. If it is less than 14%, then that is a useful screening test to tell that the child may be suffering from hereditary spherocytosis, and you have to confirm the diagnosis. Okay, how to confirm the diagnosis of hereditary spherocytosis? What test you will do? HS? For HS?
Flow cytometry.
Very good. In flow cytometry, what you will see?
CD55.
No, that is for PNH. Okay. You will see band 3 protein. Eosin 5 malleate. Okay, we do a eosin 5 malleate flow cytometry where we see for band 3 protein. Okay, so that binding protein is done for for the diagnosis of your disc. So that is one thing. Good. So next thing, LDH. Okay, LDH goes in favor for what?
Hemolysis, intravascular hemolysis.
Very good. Or what about the Coombs test?
Coombs test to test for if there are any antibodies against RBCs. Sir.
So Coombs test
Yes.
positive means
Autoimmune.
what do you? Very good. Autoimmune hemolytic
So
anemia. So
apart
what
from
about
that,
the
any other, like you are telling about to ruling out of etiological factors for home test. In this case, if you think this case is thalassemia, home test is important.
No, sir.
Hmm?
No, sir. No, sir. In cases of thalassemia,
Important. Yes. Still, both indirect and direct home test is important before transfusion because the child undergoing recurrent transfusions. So transfusion associated reactions, immunological, immune mediated. Okay, so we need to know.
So whenever a child is going on recurrent transfusion, there is a higher chance for developing autoantibodies. Okay, allo isoimmunization. What is allo isoimmunization? What do you mean by allo isoimmunization? So whenever you go for a recurrent blood transfusion, your immune system will form some autoantibodies or antibodies against the antigen. So what happened initially? The child was not will never have any reaction, but on a frequent blood transfusion, suddenly the child developed auto reaction, right? So suddenly the child is having allergic reaction, and you are giving the same unit blood. That one is you are giving the same group which you are giving previously for a long time. So at that time, you have to suspect this all isoimmunization. All isoimmunization. As a result, you have to find out the autoantibodies. So that's the reason why you have to do a Coombs test in any child who's having a who's in a recurrent blood transfusion. Okay, that's the way. That's the reason. So about reticulocyte count. So with the help of reticulocyte count, what do you differentiate? How the reticulocyte count will help in hemolytic anemia?
if reticulocytes are increased in blood, then there is increased requirement of RBCs from the bone marrow. So the bone marrow sends out these immature RBCs into the blood cells.
So
So
that's the thing.
whenever increased demand of RBCs.
Okay, if retic count is low, so what do you will suspect?
Retic
there
count
is
is
some-
low. So if there is
what do
if
you
the retic
suspect?
count is low and along with reduced RBCs in the blood, then there is a bone marrow aplastic anemia. Like there is
Very
decreased.
good. Very good. Bone marrow,
Decreased.
exactly. One is your aplastic anemia or bone marrow infiltration, hypocellular bone marrow. Second one is infiltration because of malignancy. That's infiltration. As a result, the retic count is decreasing. Third one is your nutritional. When there is no folate, when there is no vitamin B12, when there is no iron, that's insufficient production. As a result, the retic count cannot be increased. So one is nutrition, one is malignancy infiltration, that is aplastic anemia, which could be a genetic cause or an acquired cause. And fourth one is important. That's why hemolytic anemia, which hemolytic anemia will have a decreased retic count compared to the anemia, that's hemolysis. There is more hemolysis, but retic count is
Aplastic.
low.
Aplastic anemia.
Aplastic anemia is not a hemolytic anemia. Never say aplastic anemia and hemolysis. It's not a hemolytic anemia. So autoimmune disorder is there to cause hemolytic anemia. But in hemolytic anemia classification, your aplastic anemia is come under acquired pancytopenia. Pancytopenia is different, hemolytic anemia is different. Okay. So your thalassemia, this is the thing why I have to ask. The examiner will ask this because thalassemia will have an inadequate retic count when compared to the level of hemolysis. The hemolysis is more. So when you want this more hemolysis, there must be equal amount of retic count should be there in your blood. But that mismatch happens. So retic count is increased, but not to that level, the hemolysis is occurring. So that it's not compensating. So that's this imbalance. As a result, the retic count is relatively low. So this is the one condition where the retic count is low compared to the hemolysis. That's a disproportion. Okay?
Yes.
Okay. So what are the
Can
result in this?
say some peripheral smear findings in thalassemia?
Okay.
There are cystocytes and RB small RBCs are seen, sir. Microcytic RBCs, microcytic hypochromic RBCs.
Hypochromic.
There are RDW is increased, sir. Red cell distribution.
Uniform RBCs, anechocytosis and poikilocytosis, polypometria. Okay, and anything else? Sometimes even Hubble-Joly bodies and Hens bodies. Hens bodies commonly seen in G6PD, but sometimes it can happen in thalassemia also because of massive splenomegaly. Okay, but in iron deficiency anemia, you can see only microcytic and hypochromic anemia with variable size of RBC.
Yes. Continuing with the investigations. Should I continue? We'll check for serum bilirubin and HB electrophoresis is diagnostic, sir, to thalassemia. And even more
What is the
diagnostic.
diagnosis? Which is the more investigation of choice?
Investigation of choice is for confirm the HB electrophoresis can be done.
No, it is not. Yeah, its book is there, but
HPLC.
it's more HPLC because HPLC is a quantitative test. HB electrophoresis is semi-quantitative test. HB electrophoresis and HPLC, you can use both for confirmation, but the more specific will be your HPLC because that is a quantitative assessment. You will be giving a percentage, exact percentage of each hemoglobin. Whereas in HB electrophoresis, it's just a semi-quantitative. It will not go fully. So it is not that much specific compared to HPLC. Both can be used for the diagnosis, but HPLC is more in the favor compared to HB electrophoresis. Okay? Okay. And most the diagnostic one, when you go to detail, you go for gene evaluation, genetic evaluation for beta globin. What beta globin mutation is that? This is the ideal, more ideal, but that is not feasible for everyone. So we with the standard of investigation will be HPLC. But if you want to go into detail, then you can do beta globin gene detection analysis, mutation analysis.
Yes, sir.
So
yeah.
X-ray
skull.
So what is the finding you will see in the X-ray skull?
Hair on skull appearance.
Why the hair on skull appearance appears?
Extramedullary hematopoiesis because of that.
Where? In what area in skull it happens?
Diploic.
Very good. Diploic area. So diploic area get expanded as a result that is hair on end appearance kind of picture you will see in the X-ray. So now tell me, how do you differentiate thalassemia trait versus it already discussed, but in order to clarify so that everyone who's watching or who will watch in future to know how this is a commonest question which we ask in any thalassemia case. How do you differentiate thalassemia trait and iron deficiency? Tell the point. You tell that.
Thalassemia trait and iron deficiency anemia, sir.
Yeah, iron deficiency anemia and thalassemia trait.
Thalassemia trait, hepatospleenomegaly might present after 6 years of age.
I guess in both iron deficiency anemia, no, thalassemia trait will never present. It is asymptomatic. You should know that. We are not talking about intermedia. We are not talking about intermedia. We are talking about trait, carrier. Trait and carrier are always asymptomatic. They never develop the condition. Okay. So you just see the RBC indices. Only with the RBC indices, how you will classify it is the thalassemia trait or thalassemia carrier. So thalassemia trait and iron deficiency anemia. You already told it. You just refine it. In both your hemoglobin, in both, you tell that in both hemoglobin level will be low, right? Hemoglobin level will be low. What about the RBC count?
RBC counts, iron deficiency anemia also it will be less than.
Very good. In thalassemia trait?
Normal.
Normal
Yeah,
or
this
high?
is the
Very good.
normal or high. Good. Now with this, what about the MCV in both the cases?
MCV in both
MCV.
the cases microstatic.
So it will be low in both the cases.
Hmm.
Now, then do you mean by Menzer index? Menzer index. Menzer. MENTZER. Menzer index.
I don't remember exactly. So like it's
So
a
the MCV
it's
by
a fraction.
MCV divided by RBC count.
That's the
Okay,
reason
so
why I asked the RBC count and MCV. That was the clue for you. The Menzer index is nothing but MCV by RBC. So now you tell MCV by RBC count is equal to Menzer index. So in iron deficient anemia, what would be the Menzer index? And in your thalassemia rate, what would be the value?
Oh, I'll just see. In iron deficiency anemia, Menzer index is more.
Very good.
Thalassemia
Good.
is less.
very good.
It's very good. Good. What about the ferritin?
Ferritin levels in iron deficiency anemia, it will be more. It will be lesser. So
Good.
iron is
In thalassemia, right?
in thalassemia it is normal.
Normal or high? Okay. About the very important recent changes you will see about the, recently we were talking about the CBC smears. When you go CBC diseases, you will be seeing hemoglobin, MCV, MCHC, RDW. Now they have also started to go to see the reticulocytes. So now the reticulocyte hemoglobin content, when you see the reticulocyte hemoglobin content, is very sophisticated instruments. I guess in Zipper, I guess it will be there. When you go in your posting or in hematology lab, you will see this finding. The reticulocyte hemoglobin content in case of the iron deficiency will be less than 27 picogram. Okay. Whereas in your thalassemia rate, it will be more than 27 picogram. One thing. And second thing is a soluble FR, SFR. What is soluble receptor fraction? This SFR will be more in case of your iron deficiency anemia, whereas it will be normal in the thalassemia. Okay, or low, normal or like that. And then your last one thing is you will be in the family history. Family history will be positive in case of thalassemia. Whereas in iron deficiency anemia, there will be not case, there will be no positive history. So in this way, you have to differentiate your thalassemia trait and iron deficiency anemia, which is the
Iron
most
deficiency.
common question. This is the commonest question asked by examiner in your final MB exam. Okay.
Continuing with the pathophysiology.
Okay, so with pathophysiology, you're going for thalassemia. So before going to the pathophysiology, now you have investigated. So in the investigation, you found the child is having a microcytic hypochromic anemia with normal RBC, MCV, and MCSC was low, whereas iron studies are within normal limit, and Coombs test is negative, LDH is rise. Okay, and then you do an HPLC. In HPLC, you found the child HbA2 is 5%, HbF is 90%, and HbA is A2 is 5, and HbF2 is about 95%, and your HbA is undetectable. So what would be your inference?
HbA is undetectable.
HbA1 is undetectable, HbA2 is 5%, and HbF is 95%.
The baby is less than 6 months of age. That
Now the age of the child is 4.5 years.
okay, 4.5
Now
years.
Now I am doing the HPLC, and in HPLC, the child HbF is 90%, HbA2 is 5%, HbA 95% was HbF, HbA2 is 5%, and HbA is undetectable. So what could be the diagnosis? What is the diagnosis?
Patient is having thalassemia, but he's treated with hydroxyurea.
No.
Thalassemia major.
It is the thalassemia major. Simple diagnosis is thalassemia major. There is no if I would have said you the use of hydroxyurea, then you can say. But I didn't mention the hydroxyurea. Okay. So it's a simple diagnosis is thalassemia major, beta thalassemia major. In the same case, if the child hemoglobin F is 10%, HbA2 is 6%, HbA is 80 to 80%. HbA2 is 80%, HbF is 10%. Okay, and the remaining 7% is your 5% is your HbA2. So what is this diagnosis? And the child is not on frequent transfusion. Is required transfusion only during any stress, like during surgery, one of surgery required transfusion. Beyond that, there is no transfusion. The child is normal. HbA2 is 5%, HbA1 is 80%, and your 10% is your HbA. What is the diagnosis?
Thalassemia trait.
No, it is thalassemia intermedia.
Intermediate. Thalassemia
It is
trait.
non-transfusion dependent thalassemia because I say the child required transfusion during surgery. Okay, it's infrequent. And final is HbA2 is A2 is 7%. The child is having HbA2 is 7%, HbF is 1%, and HbA is 90%. What is this diagnosis?
Thalassemia trait.
Okay. Okay. The same case, HbA2 is 4%, HbA1 is 90%, HbF is 2%. Okay. So, and when you do an iron study, in iron study, you found the child is having ferrous low, ferritin low, TIBC is increased, and transferrin saturation is low. So now you see how to proceed with this case. Did you get the question?
Once again, repeat.
See, the child is having HP. When you did a
HP.
child of HPLC in anemic baby,
So there
you
is
saw that the hemoglobin F is 1%,
F is 1%.
1%, HbA2 is 4%. Like it's less than 3%. Okay, it's normal, 3%. And HbA2 is 85%. Okay, 85%. HbA1, the normal HbA1 is just 85%. And HbA is 3, A2 is 3%, and HbF is 1%. And when you do an iron study, because the child is having microcytic hypochondria, you found as in ferritin is low, iron is low, TIBC is high, and RCT with a reticulocyte hemoglobin is 25 picogram. So what do you interfere with this case? So what the iron indices is saying? Yeah, what
iron
the iron
deficiency.
indices is. Yeah, exactly. So iron deficiency anemia. There is an iron deficiency anemia, but at the meantime, this HbA2A1, the normal HbA1 should be above 90%. It should be 91%, but still the child is having 85%.
So this will be thalassemia trait.
But HbA2 is just 3%, which is normal. How come? Why? The answer is because in iron deficiency anemia, there will be a low normal HbA2. So in this case, you cannot diagnose whether the child is having a trait or not. He may be having a trait because it is being now masked by your iron deficiency anemia. So in this case, you have to treat this iron deficiency anemia. You have to give iron therapy for 3 months and you have to redo the HbA1c. If it is because of iron deficiency, then it will unmask and then you will know the actual HbA2 or it will be around 7%. And after giving therapy, it becomes 7%. So it was because of iron deficiency anemia, the HbA2 was low normal. Actually, it is after treating the iron deficiency anemia, now it came as thalassemia trait. Okay.
So one
So
more
in this
scenario.
way,
Yeah. I want to give one scenario. So one baby, they are known case of hepatospleenomegaly. Okay. They are receiving multiple transfusion, but still now they're not diagnosed. Just 1 or 2 days back, they received transfusion. They're coming to you. So you want to confirm the diagnosis. So how you confirm the diagnosis on the child at the time? Just 2 days before only the child was transfused.
Will perform CBC complete blood count and serum iron concentration will check, sir. And then
2 days back only the child was transfused, no? So that incident, everything will be mostly it's kind of normal range, okay? Because it's replaced by that adult RBC.
So this was the answer. You never do any test when the child has been transfused, recently transfused. You have to wait for another 2 months because your lifespan of your RBC is just 60, 90, 90 to 120 days. So after
Even
two
if you
months,
do
you have to
HPLC also, it will give false impression. It will
false
be normal
impression.
at the time.
So
Okay.
never do any test. If your child has came with a recent blood transfusion history, so you have to wait for another 3 months. We say after 3 months only you have to repeat all the tests.
But recently
Okay.
they introduced one more test for that. Instead of waiting for 2 months, you can assess one gene mutation. Okay. It is beyond that level, but still if we can.
Okay. So how do you proceed with? You already have a diagnosis. You found it was a thalassemia major, beta thalassemia major. So how do you proceed with this case?
yes, sir. Coming to the mechanism, first we'll correct the anemia by frequent blood transfusion, sir. And then
So what is
So
the now? What
yeah,
is the
anemia by
transfusion?
blood transfusion. No? So you should know all cases whoever diagnosed with thalassemia, they need transfusion or any indications are there.
yes, sir.
You
When it is impairing their growth, their
very good.
Very
development,
Failure
good.
to thrive.
Hmm.
and
Then what
then
are the three conditions? One thing is
when there are severe symptoms of
Anemia.
if there is
Very good.
severe
Severe
anemia.
symptoms of anemia, like they are not
good.
feeding, lethargic. Okay.
Good.
Poop.
Third one
Uh,
is
so,
Then evidence of
then
extramedullary hematophysis, what you said already, hemolytic phases, okay, and
Yes.
hepatosplenomegaly, that also an indication. And let final one, hemoglobin is less than 7 for 2 occasions, at least 2 weeks apart. Okay, these are all the 4 definitive indication in thalassemia child you need to transfuse.
transfusion. So what are the transfusion schedule you know of? Enumerate the transfusion regimen for thalassemia. Do you know the transfusion regimen?
no.
What is known as moderate transfusion regimen? Hyper threshold, moderate threshold, hyper threshold, super threshold. In moderate threshold, you have to keep the hemoglobin more than 9 grams before the next transfusion. The hemoglobin should be more than 9. In super transfusion, in hypertransfusion, it should be more than 10. And in case of super transfusion, it should be more than 12. What we are using right in our hospital setup, in any hospital, in any setup, we do go in favor for moderate transfusion threshold. In moderate transfusion schedule, we want to keep the hemoglobin above the 9 gram so that the child will have a normal growth and development. There will be a normal, there will be no extra hematopoietic extramedullary hematopoiesis. There will be no splenomegaly, and also the child will thrive well. For that only, we have to keep hemoglobin more than 9, for which we have to transfuse blood at the rate of 5 ml per kg per
5
hour.
ml.
That is, 5 ml per kg per hour. Total is will be 15 ml per kg. That has to be given every 21 days, once in 21 days, so that you can keep hemoglobin more than 9.
9
If you do this in that way, the child will not have any hemolytic phases. You will not have any organomegaly. You will have a normal growth and development. So we follow a moderate threshold transfusion regimen. So you should know that. Okay. So what that is that another one thing. Okay, what are the complication you will be expect manage the complication of blood transfusion? So what are the complication of blood transfusion?
Immune reactions, sir.
Okay, immune reaction, that is very less because right now whatever blood you are using are leukodepleted. Okay,
Can
all are
divide
leukodepleted.
complications in two ways, like immune and non-immune. Okay.
Non-immune.
So, and immediate, acute, and chronic, like that you can divide in two ways. Okay. Within first 24 hours of transfusion, what are the complications expected in those side? One is febrile non-hemolytic reactions, like fever, okay, tachycardia, all the things. And second one is hemolytic transfusion associated reactions and bacterial contamination and trally.
Trally. What is trally? Trally. What is TRALI? Trally. You have learned it. It's important question in your pathology, Robbins pathology.
Okay,
It is in the
transfusion
Robbins pathology.
associated
The
lung
acute injury, acute lung injury.
acute lung injury.
Transmission.
Then some
Transmission of-
anaphylactic reactions also. Okay, these are all the expected complications within 24 hours of life. Okay, so for trally, main feature is hypoxemia.
Yes,
That usually more commonly associated with platelet transfusion than PRBC. So whether you plan already, okay, this case is thalassemia, we want to do regular transfusions. So what are the type of RBCs are available?
Very good. Yeah. Then what are the RBC which is available in any blood bank? What are the type of RBCs? What is whole blood RBC? Whole blood. What is packed RBC? So we are asking that. So what do you transfer? What they transfuse in thalassemia? Whether it's whole blood
In
or it's
thalassemia,
packed rates? We use.
we use packets less than 120 days. Sorry, less than some 120 days or something.
So use packed red RBC. So use a packed RBC. Okay, so packed RBC. You use whole blood. Why we don't use whole blood rather than packed RBC? Why we don't use whole blood? Whole blood rather than PRBC.
I don't know.
One thing is whole blood. The volume is more. Children are very small, so based on the weight, one immunological reaction. Whatever the sir told right now, na, what are the complications? That complication are more in if it goes in your whole blood compared to your packed RBC. Volume is more in whole blood, reaction are more in whole blood, and importantly, your infection transmitter. The infection are more transmitted in the whole blood rather than your packed RBC. Because packed RBC is just RBC. In RBC, has no nucleus, right? Whether RBC
Yes,
is
sir.
nucleated or non-nucleated.
Non-nucleated.
Yes, sir. One more thing,
So-
you need to ask about leukodepleted or irradiated RBC here.
Yes, sir.
Why?
So normally,
Yes, sir.
why, sir, is asking, why leukodepleted? What is a major infection that is that prevent the because of leukodepletion, you prevent one infection. What is that infection?
HIV and
No,
HIV
HIV.
is in the training. Leukodepleted is mainly for CMV.
CMV.
CMV
Okay,
infection.
cytomegalovirus.
Exactly.
Okay.
Cytomegalovirus.
Yes, sir.
Apart from that, you can avoid some febrile non-hemorrhagic reactions also, because we are removing most of the cytokines. No, that's the reason. Okay. So, and one more thing, for how they are doing leukodepletion means they may do by pre-storage or pre-transfusion. We should use filters. Okay. So before transfusion, you want to check cross-matching, is it?
Yes, sir.
Correct. So routine cross-matching or anything extra you want to do in this case?
You have to see what other thing you have to see apart from routine.
Here they used to do extended RBC cell typing. Okay, that means they are checking for minor blood group incompatibility also. Example, minor blood group incompatibility are kind of small c, capital C. Okay. So because this child is going to transfuse multiple transfusions in almost entire life now. That's the reason we should do extended RBC cell typing. Okay. Okay. And
So
some one or two questions, like if father or mother they want to donate the blood means, can you allow them?
Sir is asking whether the mother or father can give blood to their own baby or not.
Depends. Depending on the blood group only, we can say nothing.
Yeah, if same blood group father also having, the child also is having same blood group. Shall we allow? No, we should not. Because
Father
they
might
may
have
be the
a trait.
Yeah,
Thalassemia trait.
exactly.
yeah, even
Yeah,
the
he's
triad
having
may show,
thalassemia.
they may be the donor of hematopoietic stem cell in future.
Yes.
Okay, so if you donate the blood, chances of graft versus host disease rejection are very much. Okay, that's the reason we are avoiding. Okay.
No.
Okay, so right, you tell me. So this are the same thing. What we told that this is the as the AAP guideline. This is the moderate threshold transfusion guidelines. So you have a target pre-transfusion should be above 9.5. The blood product should be packed RBC with hematocrit more than 60. Ideally, we say 75%. Cross-match for, as you say, extended blood antigen RBC antigen cross-matching where you have AB or RH and all your minor antigen. And frequency should be 3 weeks. And the volume should be 15 to 20 ml per kg. The rate should be 5 ml per kg per hour. And should be leukodepleted for the CME infection and the screening for all the transfusion dependent infection like hepatitis B, hepatitis C, HIV, malaria, and these are the things you should see. This protocol. What I discussed, what I told is that the same
Yes, sir.
protocol. This is the moderate threshold transfusion protocol for the thalassemia. This is the most common
This is
threshold
for
for
routine,
diabetes.
okay, but like this side, you to check hemoglobin. Hemoglobin is very important. That's the factor to decide about volume of
Blood to
RBC
be
transfusion.
transfused.
Like if any child having hemoglobin is less than 5, you cannot give 15 ml per kg over 3 to 4 hours.
Yes,
You
sir.
need to divide the aliquots, like RBC, in 2 aliquots. Initially 5 ml per kg, then after 12 to 14 hours, again 5 to 10 ml per kg. Because if you give more amount of RBC in failure or severe anemic child, high chances of aggravating cardiac failure and sudden cardiac death also. Okay.
Why, as the sir said, if we go hemoglobin less than 5, why that's the chance of cardiac failure in the children? What is the cause?
Um,
There's logical thinking. Why does we want hemoglobin? The hemoglobin is low, but at the meantime, I cannot
increase
give him more hemoglobin. Why the child is having more risk for cardiac failure if the hemoglobin goes less than 5?
the preload. No.
Okay, preload, whatever, but the heart is functioning, right? Why the heart is going for failure? Because there's no damage to heart.
Capacity might be low, like so.
No, whenever the child is in chronic hypoxic state, when the hemoglobin is less than 5, already the heart is not, the heart is receiving blood, but the blood is completely hypoxic. And your heart also required oxygen, right? Heart musculature also required oxygen. When the child is undergoing a chronic hypoxia and the heart muscle is not, it's depleted of oxygen, the myocardium become weakened. So because of this hypoxic state, the heart muscle become weakened. So that is the reason why they go when you give a sudden large amount of blood, it will suddenly go into a failure state. So that's why you have to give in the adequate level as Sir said. Okay, that is the reason why you have to give an adequate level in the case of any hemoglobin, severe hemoglobin less than 5.
Yes, sir.
Okay, so you should know another big thing. So what is the main give hemoglobin? For example, for every 3 ml per kg of your PRBC, there will be a raise of 1 gram per deciliter of hemoglobin. For every 3 ml per kg giving of PRBC, every 3 ml per kg of PRBC raises 1 gram. So if the child hemoglobin is 7 and I want 10, so how many ml I have to give? I have given this simple mathematics. 3 ml per kg. Yeah, good. 9 ml per kg. So I have to give 9 ml per kg so that in one transfusion itself, the child will go about 10. So if it is 5, what you 5? How much you have to give?
Yep.
I have to raise to 10.
To raise from 7, is it?
No, I have to rise from 5 to 10. If
5 to
hemoglobin
10,
is right
15.
now 5, good,
15.
15 ml per kg in aliquot because the hemoglobin is very low. So I cannot give at a one stage. I have to divide and give it.
Yes, sir.
Okay, so that is the 15 ml per kg. So this you should know. And why 3 weeks after? What is the reason for that term time 3 weeks? Do you know? Why not at 2 weeks? Why not after 4 weeks or 6 weeks? Why that specifically they are saying 3 weeks, 3 weeks, 21 days, 21 days? Because for every week, the hemoglobin drops by 1 gram. There will be a drop of hemoglobin by 1 gram. So if the hemoglobin was 10 at the after transfusion, within 3 weeks it will become below 7. And I want a pre-transfusion level of 9. Right? So that's the
Yes.
reason. So 3 weeks time is given. So 7 means if it goes for 7, means the child will have all these extramatic features, extramedullary hematopoiesis, phases, organomegaly, and impact growth. I want to avoid it. So that's the reason why we have given 3 weeks. Ideally,
Yes.
before transfusion, the hemoglobin should be around 9. It should not be a 7. That means I have to increase the hemoglobin at least around 12. So if I am discharging the patient at 12, after 3 weeks he will become 9. Then again I will transfer so that I can keep around 10.5. So this is the way you have to transfuse the patient. So that is the idea behind, because at the point of 9.5 they were keeping so that there will be optimum growth and development. There will be no hepatospleenomegaly, and there will be no the chipmunk phases development. So the child will have a normal growth and normal. Yeah, that's the reason why the hemoglobin value, the time interval, the rate and the volume has been decided accordingly for that purpose only. Okay. Okay. Next.
Yes.
So
Supportive therapy will be giving
yeah. Okay. Now tell me,
folate and vitamins.
why the need of folic acid in this thalassemia major?
It
What
helps
is the
in
nature of? Good. One thing you should know that thalassemia patient, in any thalassemia major, we give only folic acid supplementation is must. If you see any patient, we don't give iron, we don't give vitamin B12, but every thalassemia case, every thalassemia patient, they prescribe this folic acid. Right. Any idea? See, as you say, same thing. Hematopoiesis, when bone marrow requires, normally, we give blood transfusion. So, as I said, moderate amount of blood transfusion, we give 15 ml per kg, and most likely at one go, we want to raise only 3. We cannot raise 5, 7. It will go in against our favor. It may be a detrimental to the baby. So we mostly try to raise 3 gram in one sitting. We cannot raise 5, 6 gram at one sitting itself. So we raise 3 gram. Apart from that, it has been found that in this moderate threshold, the extra 1 gram that has to be going to be raised will be given via bone marrow. So bone marrow has a capacity to rise by itself of 1 gram per deciliter without having any extramedullary hematopoiesis. For that 1 gram per deciliter rise, the bone marrow, the erythroid precursor, needs nutrition. One is iron. Already in thalassemia, iron is overloaded. Your iron is done in the body. So I don't want to give a supplementation. Number one. Second is vitamin B12. This vitamin B12, normally in all human beings, we have a plenty store. Irrespective, we have a vitamin B12 deficiency because all are non-veg. Exception is vegetarian. If you are not a vegetarian, if you are pure vegetarian, you don't have any source, then you will be a vitamin B12 deficient. Or else, most of us are plenty with the vitamin B12 store, and we have adequate store in our liver. So that's the reason why there's no need of a vitamin B12 also. But folic acid, we are deficient. We don't have an adequate store. So we need folic acid, we need iron, and we need
Vitamin C.
Yeah. So vitamin C is not important for your production hematophagocytes. That's for iron absorption. And I don't need any iron absorption here, right? Vitamin C
Yes.
is to improve your iron absorption. If only this vitamin C is given for dexperoxamine infusion. So it is about chelation therapy. Vitamin C is not given for as thalassemia. Okay, so that's the reason you should know about the thing. So after that, so when you give an iron is already present, vitamin B12, only folic acid is deficient. So you give everything here so that hematophagocytes will occur in a proper way. You have an effective hematophagocytes. As a result, the 1 gram, extra 1 gram will be provided by your bone marrow. Whereas the 3 gram you will give it by your blood and 1 gram by your bone marrow. So totally you can raise a 4 gram. So that is the idea behind giving folic acid supplementation in all thalassemia major case. Okay. So okay, what now and final thing is when you go to treatment, you have a iron chelation. So what is the indication when you should see the iron monitoring? When you have to see this iron overload? What are the causes of iron overload in thalassemia?
Because of increased iron content due to destruction of RBCs and the precipitation of H hemoglobin, there is a increase in the blood cells. So when the serum ferritin rises above 1,000 micrograms, then it to start with chelation therapy. Sir.
Okay. Serum ferritin is more than 1,000 and after 10 transfusion.
10
And
to 20
also,
transfusion.
if you go for serum, liver iron study, when you go for liver iron is more than 5,000 microgram per gram of your total liver, if it's more than 5,000 microgram. And if the age of the child is more than 2 years, then we start the chelation therapy. What are the drugs you know of in chelation? What are the chelation drugs we use?
Desperoxime.
So desperoxamine is a which drug? It's a what mode in which mode we give that?
We'll give subcutaneous.
Subcutaneous and
Subcutaneous. That's Sir.
Bolo, yeah, you're telling. Okay. You're monitoring serum ferritin. Okay. So now see, whenever our target for serum ferritin, if it is more than 1,000 microgram per liter after 10 transfusion, you always start with the desferoxamine, deferiprone, and you have deferi. Another one drug is def. Wait a minute, I have another drug. Desferoxamine, deferiprone, and deferistrone. Yeah, these three drugs, two are oral drugs, one is subcutaneous. Now, recently they are saying oral drug is superior compared to the subcutaneous because you have to give the dose is OD orally and they have less side effects. Okay. At this stage, you don't need to know the much detail of side effect. So when to stop, if ferritin level goes less than 500, you can stop the chelation therapy.
Yes,
okay.
But here, I want to ask one more question. So, like, after 10 to 12 transfusions, we need to check serum ferritin level. So if you're checking, it's around 600 and 660, okay, microgram per liter. So again, we are repeating that test after 3 to 6 months. Suddenly it went 6,000. What's your impression? From 600 to 6,000 within 3 to 6 months.
So there is a immune reaction, hemolysis, which is happening.
Okay, there any other reason?
What about
serum
this one condition?
Acute phase reactant. Okay.
Yes, sir.
So infection like transfusion associated hepatitis B, C, A, like any infection can lead to this much ferritin level. Like that's the reason we should not take only serum ferritin level. It's kind of acute marker.
So now the recent changes, what are the recent changes right now? You have already given in that. We see, yeah, this is the T2 star MRI, about 8 to 10 years of cardiac MRI and liver R2 star MRI, where we do the concentration of the iron can be studied with the help of the T2 sequences. So if the T2 sequences are high, that it suggests that the child have more iron overload. So in that way, we can that are the marker rather than going for serum ferritin, because they are not going to be get changes according to the ferritin level or your inflammatory state. They are independent of any ferritin. The serum, the ferritin is that is stored, ferritin or iron that is loaded in your heart as well liver can be measured with this special MRI technique, T2 and R2 technique. With that level, we can say this patient is iron overloaded. I have to go with the chelation therapy. So bone marrow transplantation, what type of bone marrow transplantation you will suffer, when to do, and before which age you have to do, so that you have survival, thalassemia pre-survival. So all is given here. So you just read it.
Yes, sir. The optimal age is some 2 to 10 years. And the patient status should be optimally chelated, no organomegaly, no organ dysfunction. The ideal donor is fully HLA matched sibling donor or parent donor. Optional donors are patch and unrelated donor and haploid identical donor from family.
Okay, good. So as the 2 to 10 years is okay, but if they anyone want to say specific age group, you can say less than 7. That would be ideal, because less than 7 years, their liver is not going to be much affected with this iron overload. And if they are optimally chelated, there is no complication, there is no other complication, then I will go for this full HLA mass sibling allogenic HSCT. One is hematopoietic stem cell transplantation. So, do you know of any classification, risk stratification for this SCT transplantation for the thalassemia?
No, sir.
That is a class. Just go through the classification that's known as PESARO, PESARO, PESARO classification. So in this classification, we see 3 things: liver cirrhosis or hepatomegaly, iron chelation, hepatomegaly, liver cirrhosis, and iron chelation. Based on these risk factors, we say if there is no risk factors, then 98% survival free, the child will have a 95% thalassemia survival, thalassemia free survival. If there is one or more risk factor, then the child have 90% thalassemia free survival. If there is more than 2 risk factors, then the child thalassemia free survival will be just around 80%. That is known as
80%.
PESARO 80%. That is known as PESARO classification we use for the risk stratification before any bone marrow transplantation in a thalassemia child. Okay, this is the final end. So finally, your current person beta thalassemia major. You were discussed about the treatment, the way you diagnose the case and how to differentiate from other thing, and also we discussed about that. Good. So you have wrote it. I want to ask this question only. You have given this. So recent new changes in thalassemia major. So normally what we talked up to diagnosis frequent regular transfusion according to your moderate threshold PRBC transfusion, followed by iron overload reduction strategy, that's your chelation therapy and monitoring of the child, and finally you go for bone marrow stem cell transplantation. But recently, the various research trials and studies were found, and they have introduced few drugs. And one of the drugs you have given here is this luspatercept. So luspatercept, what is the mechanism of action? You right know?
It's like anti-apoptotic, so like usually due to clumping of due to precipitation of the hemoglobin, there is apoptosis of heart disease. Like so that will prevent that, and it will
This
prolong the.
Losap set, you go with that the chart, right? What is a beta thalassemia? You had made a flow chart of beta thalassemia pathophysiology. Go to
Yes.
that slide.
Okay.
Yeah. So here, what happened? In this, you have beta globin chains are reduced, so you have unpaired alpha chain. Now, this alpha chain gets include precipitate, and what you did intramedullary death of erythroid cells, right? One is in RBC, this alpha chain will form an inclusion body, they will form Eames body, and they get destructed and go for hemolysis. In same thing, when this inclusion body form in your erythroid precursor, what happens? The erythroid precursor get degenerated, they get destroyed. So there will be infective erythropoiesis. So now this Lusta, this new drug, what that drug is, you are sorry, luspatercept. Okay, this is not luspatercept. It's a recombinant fusion protein that is made up of your TGF beta family. It belongs to TGF beta family. This will block this ineffective erythropoiesis step. That step where we at that pathophysiology of that particular area of your beta thalassemia, ineffective erythropoiesis will be stopped. As a result, it will give some. It will buy some time for an effective erythropoiesis, so that you form a full matured RBC without this without a global mutation. So when this luspatercept was given, in 70% of patients, it has reduced the RBC transfusion. Okay, it has reduced the RBC transfusion. Okay, and what is the gene therapy? You know, now the name is given for the gene therapy.
TGF2.
What is the gene therapy?
TGF2 gene therapy.
No, no, no. It is not TG. That TGF beta 2 is luspatercept. I am talking about the gene therapy. You are right, gene therapy, right? It's not available at this time. It was under the production. It was not available. Now it is made available, and it has been added in books also. So, what is that gene name? Genetic name?
Mm, I don't know.
Wait, I was okay. That name is Betty Beglozin automaticel. Okay, Betty Beglozin automaticel. So this is giving you it's kind of Italian name. All this French, German's name, so we don't remember it. So this Betty B. Glogin automaticin, which is approved by the FDA in 2023 for adult and pediatric patients more than 4 years with transfusion-dependent beta thalassemia, which is an harvested autologous CD34 T cell. Okay, so CD34 T cell harvested autologous CD34 T cell, which is incorporated into a lentiviral vector. So that's what lentivirus vector, in which this CD34 T cell is incorporated, and it has been transplanted into the patient of beta transfusion dependent beta thalassemia, and it has achieved 90% remission from transfusion independence. So 90% people become independent of transfusion. They never require transfusion after this gene therapy. So this is known as BTP glogene automaticin gene. So this is the recent advances of your beta thalassemia treatment.
Yes,
I
sir.
think
Okay.
about 2 hours over. Ah, so okay, fine. Preventive measures nowadays we are going for antenatal screening and diagnosis. Antenatally, we should screen from the basic of CBC. If they have that history, then you need to do genetic testing antenatally. So we need to prevent
Yes, sir.
thalassemia. How that era is going to prevent thalassemia from antenatally.
Yes, sir.
Okay. 1 minute. You make Parthiban as a co-host. Okay. He's become co-host. You are in host, right? So you can make Parthiban as
Yes,
co-host.
sir.
You make him.
So
So
very
you
good
came with
presentation.
today.
Sir, I'm
Yeah.
not. Yes, sir.
You are a co-host. You can make a co-host. Yeah, this the presentation was far good. You presented very well. we started to discussion from the complaint, from the presenting complaint to the case summary and the diagnosis, how you have to interpret your diagnosis, and also we discussed about the investigation management and complication related to the thalassemia per se and thalassemia treatment. And finally, we also see the newer modalities in the beta thalassemia, transfusion dependent beta thalassemia treatment. And hope everyone who watched this
Most of the
series,
questions. Yeah, but main thing you should focus on anthropometry. Okay, as a pediatricians, we are always look for anthropometry. Okay, so weight, height, head circumference. Okay, all the things are mandatory.
Thank you, sir.
So thank you so much for the presentation, sir. This is Nitish, sir.
okay.